So in terms of national clinical guidelines themselves, this section is going to talk a bit about the whole prioritisation process of national clinical guidelines and the quality assurance criteria. This is, as I had referred to, our earlier document in terms of prioritisation of national clinical guidelines. We have now agreed that in terms of guidelines coming to the NCEC, we will have 3 streams. Within those streams, we will have a prioritised stream for a major patient safety item, or where we might do some horizon scanning and say, internationally, the UK, the US, they really have very strong national guidelines on X or Y. We should be thinking about that within the Irish context. And we will support that kind of prioritised guideline through a commissioned process for the NCEC. We really think we can probably only manage up to 4 commissioned national clinical guidelines done well within the Clinical Effectiveness Committee, and this is why we have to have a prioritisation process. Our second stream are guidelines that will come through the clinical programmes. So for many of you around the table, it will be the clinical programmes that you're working on, and that there will be a dual process here, that you would either submit to us a proposal in terms of your national clinical guideline or the full clinical guideline itself. And in a way, it helps us and hopefully helps you if we start at the proposal stage, so we can work with you so that when we get to the other end, we're all at the same plate and the same stage, and we're not working in different directions. In terms of those guidelines coming through the clinical programmes, depending on capacity of the NCEC, we might transfer them to Stream 1 and they would become a commissioned guideline, so we could give a bit more support to you in terms of that. So I know some of you around the table, we have certainly supported the systematic reviews around the asthma guideline, around the paediatric early warning score, and obviously we'd be open to those kind of discussions with the emergency programme. In terms of Stream 3, we don't want to miss anything in terms of what's happening, because often the need for a clinical guideline can just emerge from somewhere offside or maybe for some of the charities. So it will be helpful to have a stream there so we can allow that to happen, to come into us. And we would in the first instance encourage that comes through as a guideline proposal and that we would work with you then. All of the guidelines, once they are prioritised, will become part of the register of national clinical guidelines that we will put up on our website. So anybody will be able to come and look and see what's coming on stream and going forward. And we're trying to get a bit forward thinking so we can be saying for 2015, these are the likely national clinical guidelines, 2016, 17, 18. So we start creating a programme of national clinical guidelines. To date, we've taken what's emerged, what's come forward, what seems to be the key critical patient safety issue, but it'd be really good to start planning and going forward. And if we align that with the HSE planning and other policy priorities, hopefully we can get that right. So our national clinical guidelines are the right ones for the prioritised items within the system. Regardless of what prioritisation stream a guideline comes through, it will go through our quality assurance processes to make sure that it is developed to the highest level that's required before it goes forward for endorsement. These are our prioritisation criteria, and I would urge you, for those of you that are working on guidelines that haven't come through the prioritisation process first, because that is a formal process, to have a look at this, because this is how we judge the guidelines and score them in terms of whether they will be prioritised for the NCEC. So whether it's a patient safety issue, the burden of the clinical topic, the evidence analysis that's available, the economic impact. So we do require that all guidelines have a full budget impact assessment, the variability in practice. And we would see if there isn't huge variability in practice, the question is, do we need a guideline? Because the biggest benefit we can get from a guideline is to reduce variability in practice and promote standardisation across the system. That there is potential for addressing health issues, because really it's not worthwhile spending all of this time and resource if we're not actually going to address a good, strong health issue. And that the clinical guideline can be implemented. We need something that's workable and doable within the system. We utilise within our NCEC prioritisation groups and committees who come together, who score the guidelines or guideline proposals that come forward, and that's presented to our committee to go forward. So that is a formal process. Our second piece of work, our second formal process around guidelines, is the quality assurance criteria. As I've said, they are based on the Agree-to tool, and we are looking to update this quality assurance criteria. And they are around the feasibility, the scope and purpose, and the clarity around the scope and purpose of the guideline, the rigour of development, so the processes used and the methodology, and I'm going to talk a little bit more about that now, the stakeholder involvement, the applicability, implementability of the guideline, the clarity of presentation, and then the independence of development. So the conflicts of interest or declarations of interests are addressed and don't actually impact or impinge on the decisions that are made around the recommendations for the guideline. And that's again about being transparent and upfront about what we're doing. I put this up here because I presented at the Cochrane Symposium a few weeks ago, and they had a cartoonist at the end of the room. And the cartoonist was obviously listening fairly closely to the presentation. And this is how it was presented afterwards. So basically, we magic up the clinical guideline. It goes through the screening process, a little bit like we go through the airport. There are a number of prioritisation criteria that are addressed. Then it's stamped to see if it's okay from a quality assurance end. Then we get the endorsements from the various places that we need to, and then we look at implementation and audit. It was a very clever piece, clever cartoon, of which I didn't know was happening when presenting.